Assalamu alaikum. I think we can start. It's 8:30 now. I'd like to welcome you to today's webinar by Dr. Ahmed Al-Rogi, who is an assistant professor and consultant ENT and rhinology and allergy and skull-based surgeon. Dr. Rogi is highly recommended by his colleagues. And as you are all aware that more and more of our members are doing procedures through the nose. It is a great opportunity to have a proper presentation on the anatomy of the nose and paranasal sinuses from an expert. Also, we have been seeing cases of fungal orbital infection, and some of them are very difficult to treat. And I thought it would be a great idea to have an opinion of the expert on how to manage these difficult cases. Dr. Rogi, thank you so much for giving us this time and joining us, and please proceed.
Assalamu alaikum, masal khair jami'an. Thank you, Dr. Rahela, for having me. The talk tonight will be, as you can see the title of the presentation, it will be about the anatomy of the nose and paranasal sinuses, and we'll have an update on the fungal infection affecting the sinus and the nasal cavity as well as the orbit. Are you hearing me okay? Just to make sure that the hearing quality is good. Can you hear me well? دكتورة هلا الصوت واضح؟
I hear you very well, and if anybody has any problems, please raise your hand. Also, I forgot to say, if you have any question, you can use the Q&A or raise your hand, and we'll give you the mic. I think we can hear. Everybody can hear. So please go ahead, Dr. Ahmed. Your voice is very clear.
Thank you very much. So the talk will be about the anatomy first. This is the outline of the presentation. We'll spend time explaining the anatomy because the anatomy is very important. Later on, when we come to the pathology, you will understand how important is that, especially the fungal sinusitis. And we'll talk about the classification. As you will see in the presentation, the fungal sinusitis is not a single disease. And not only that, because the fungal sinusitis is very diverse. Many of them are benign, others are very malignant in terms of presentation, and some of them, they carry a very high mortality rate like what you will see. So it's very important to have a very good understanding of what we mean by fungal sinusitis and how do they present, how do they look in imaging study, and then how is that going to be reflected on treatment and prognosis. Then once we are done with the fungal sinusitis, we'll try to go quickly. I know that every one of these is a separate talk, and talking about it in detail will take at least a day, or days even, but I will try to talk about the most important point about this topic. So the external anatomy of the nose, as you all know, is made up of bony framework and cartilaginous as well. The cartilaginous is not shown here because that's probably more important when it comes to aesthetic, but what is really important for the rhinologist as well as dealing with chronic rhinosinusitis is the bony framework. So we have the frontal bone, which is making most of the frontal area. We have the maxillary bone, which is making most of the midface, and then we have the nasal bone. We have two separate nasal bone, one with a midline suture. Keep in mind that we have the frontal process of the maxillary bone, which is extending superiorly, and that will be important when we later on speak about the DCR and what are the important points that you should consider. The orbital plate or the orbital surface of the maxillary bone is making a component of the floor of the orbit, as you all know. And then we have the lacrimal bone on the medial wall, or making the lamina papyracea, as well as the palatine bone or the orbital plate of the ethmoid bone, not the palatine, the ethmoid bone. So these are the most important bone that make up the external part of the nose. Some of them, they are also making the internal, as we will come to see in the next, in the coming slides. The sinuses are basically a cavity or invagination of the within the bone. So each sinus is corresponding to the bone. So we have 4 different sinuses, as you all know: the frontal, maxillary, ethmoid, and sphenoid. And the ethmoid, we divide it into anterior and posterior based on the middle turbinate second part, like we will come to see in the slides coming as well. So it's very important to know that the maxillary is supplied by the maxillary artery as well as the V2, while the frontal is supplied by the ophthalmic as well as the ophthalmic artery as well as the ophthalmic, the V1, and the V1 of the trigeminal division. The ethmoid and the sphenoid sinuses is having dual blood supply coming from the internal as well as the external. The internal is represented in the ophthalmic artery, and the external is represented in the maxillary branches. And for the nerve, as you see, it's supplied by V1 and V2. So this is for the basic anatomy of the sinuses. It's very important when you look into the CT scan to understand the anatomy of the CT scan. So this is basically a coronal CT scan showing the midline nasal septum. It's a little bit deviated to the right side, like what you see there, highlighted by the laser pointer. This is the right maxillary sinus, and this is the left maxillary sinus. And here we have projections coming from the lateral nasal wall. So when we say lateral nasal wall, we mean all the lateral nasal wall, which is more complex compared to the medial nasal wall, or what we mean by that, the septum. Okay, so the medial nasal wall is basically the septum, which is very easy to understand. It's just a flat surface, but the lateral nasal wall is the one that is more complex, and the one that the understanding of it is very important, because the drainage of the sinuses come into the lateral nasal wall. So here we have the inferior turbinate, as I mentioned earlier, and we have the medial orbital wall, which is the part of the lateral nasal wall, if we remove the ethmoid sinuses. So all these cells that you see is basically an ethmoid air cells, okay? And here we can see the middle turbinate. So we agree that this is the inferior turbinate, which is considered the biggest, largest. And then we have the middle turbinate, which is attached in its first portion, because this one we call it the vertical portion, or vertical lamellae, attached directly to the skull base, giving it more importance. And this is the middle turbinate on the left side, but this one is having aeration, and this is one of the variation that we see it sometime in a middle turbinate. We call it concha bullosa, or ballooned concha. Concha and turbinate, they are the same. So if you hear inferior concha or inferior turbinate, they are exactly the same structure. And then we have the skull base, as you can see there. So the skull base is also important, especially when it comes to any endoscopic skull base surgery. So the skull base is more clear on the picture on the left side and the right side. So you can see that this is what we call fovea ethmoidalis. We have this small area called cribriform plate, and then we have a bone connecting them called lateral lamella. So this is all considered the cribriform plate, the lateral lamella, and then the fovea ethmoidalis. They are all part of the roof of the nasal cavity, paranasal sinuses, making the skull base. This is, again, a highlight for the inferior turbinate. You saw earlier the inferior turbinate. You see it here. It's considered the largest. And this is probably the one we operate on the most, because this is the one that comes in the way of nasal breathing. So this is the one that when it gets hypertrophied, it affects the breathing. So we do a lot of turbinate reduction procedures. This one is the middle turbinate. It's more important when we come to the endoscopic sinus surgery. You see here, once we resect the middle turbinate, you see that most of the sinuses is draining into the middle meatus. We say meatus, we mean by that the space below the middle turbinate. So if you hear inferior meatus, that means the space below the inferior turbinate. And that one is only importance is as a drainage for the nasolacrimal, as an opening for the nasolacrimal duct. But this one, as I mentioned, is very important for the sinus surgery, because the frontal sinus is draining to the middle meatus. The maxillary sinus, it also drain there, and the anterior ethmoid, it drain into the middle meatus. And then we have a small turbinate superior. We call it superior turbinate. This one is small. This one is only important when it comes to the sphenoid surgery because it's close to that. This one drain only in its meatus, it drain the posterior ethmoid. Then we are left up with the sphenoid sinus, which is draining directly into a space called sphenoethmoid recess. You can see that on the right side picture. So it drains into an area called sphenoethmoid recess, which is the space just above and medial to the superior turbinate. So this is the same picture, but removing the mucosa and just leaving the bone behind. You can see now the bone, which is making up the lateral nasal wall. So here we are looking into the lateral nasal wall of the right side of the skull. So you can see that this is the bone making up the inferior turbinate or the inferior concha. It's a separate bone. You can see that the middle turbinate is highlighted here, and this one is making up the middle turbinate, and this one is part of the ethmoid bone. And then we have the superior turbinate just above it and superior to it and posterior. Then you can see clearly the maxillary sinus. This is the frontal process of the maxillary sinus. And then we have the lacrimal bone. These bones are really important when it comes to the DCR because we see some endoscopically, we see a line called anterior maxillary line corresponding to the attachment between these two bones. And this one is one of the important landmark when it comes to the DCR or dacryocysterinostomy. This part, as mentioned earlier, this is only the cartilaginous part of the, or the cartilaginous framework of the external nose. And then we are left up with other bones like the palatine and the sphenoid. Sphenoid is important because downward we have the pterygoid plate, the medial and the lateral plate, making up part of the contribution to the lateral nasal wall posteriorly. And then once we remove these structures, you can see clearly the drainage of the nasolacrimal duct into the inferior meatus to the right side, and then the opening into the maxillary sinus. It's clear there. And then we have the frontal sinus. It should drain into the middle meatus as well. So this small bone, what you see there is called uncinate process. Usually this is the first step when we do maxillary sinus surgery, because this is the one we usually remove in order to see the opening of the maxillary sinus and then proceed from there into a proper middle meatal antrostomy or maxillary sinus surgery. And then we have the sphenoid sinus like what you see in the previous picture. So this is just a repetition of what's very important, the drainage of all the sinuses. So remember that middle meatus is the most important for the sinuses because it drains anterior ethmoid, maxillary, and the frontal. And this is why any pathology affecting the middle meatus, it almost hits all or most of the sinuses, and then it might get reflected negatively on the other sinuses as well. Inferior meatus doesn't drain any sinus, it drains only the nasolacrimal duct. And then we have the superior meatus for the posterior ethmoid, and then the sphenoethmoidal recess or the space above and medial to the superior turbinate. This is draining the sphenoid sinus. This is again a CT scan. Here I'm showing in this picture or this CT scan. This is a sagittal. In the sagittal, you can see clearly the sphenoid sinus. The sphenoid sinus is usually one big cavity. It might have septation, but it's usually the most. This is the most posterior among all the sinuses. And then we have the ethmoid sinuses, the anterior and the posterior. So the anterior is usually having having multiple cells, but small in size. This is the anterior ethmoid. And the posterior ethmoid is usually bigger cells in size, and they are few in number. We divide between them by a line which is corresponding to the middle turbinate. So the middle turbinate is actually, its anatomy is complex. I don't want to get you involved in that because understanding its anatomy, you need a talk alone. But the middle turbinate is actually not a straight turbinate, the same like the inferior turbinate. The inferior turbinate is just a straight turbinate all the way to the posterior end of the nasal cavity. The middle turbinate has 3 parts. Okay, so the part I showed to you earlier was the first part, which is attached to the skull base. Then it turns laterally So the first part actually is sagittally oriented. Then the second part is turning lateral to be coronally oriented. So you will see it much more clear when you look to a sagittal, because it will be like a line there. So this second part, the one which is coronally oriented, it will make a separation between the anterior ethmoid, which is anterior to it, and posterior ethmoid, which is posterior to the second part of the middle turbinate, or what we call the basal lamella. So these are the most important. Then we have the frontal sinus, which is the most anterior and superior sinus among all the sinuses. Here you see the axial cuts, and the same thing. Here we can see also the anterior ethmoid, posterior ethmoid separated by the second part. So we agree that we have the first part, which is sagittally oriented, so it should be like that. Then it turns lateral to attach to the lamina papyracea. That bend make separation between anterior and posterior ethmoid. And then we have the sphenoid here, where it drains into the sphenoethmoid recess, as you can see. The third part, or the third picture, is actually coronal. So this is showing the ethmoid posterior one, and part of the sphenoid is shown as well. You can see clearly the inferior turbinate and then the posterior end of the middle turbinate. So the sinuses are basically a cavity within the bone, the corresponding bone. They are lined by respiratory epithelium. Their morphology is variable. They have sometimes certain anatomical variation. They are almost surrounding the eye from medial and from posterior and superior. So we have from medial, we have the anterior and the posterior ethmoid air cells. From posterior and medial, we have the sphenoid sinus, and then anteriorly, we have the frontal sinus. It's very important to know that any pathology like sinusitis, chronic or acute, it can get complicated by intraorbital complication. A good example for that is the subperiosteal abscess, where we see it very frequent. Here you can see this is a view from the cranial vault, where you see the floor of the anterior cranial fossa, just to show the crista galli as well as the orbital plate of the frontal bone. And here you can see the planum sphenoidal, which is part of the sphenoid sinus. All these are barriers between the anterior cranial fossa as well as the nasal and paranasal cavity. Here you can see clearly the medial nasal wall. So we spoke about the lateral nasal wall, where you saw the component of that comprise that make the lateral nasal wall. Here you can see the septum, which is the medial nasal wall. So you see that here we call this the perpendicular plate of the ethmoid sinus, or ethmoid bone. And we have vomer, which is a separate bone making a contribution. And then the remaining part, the one which is going to be in this area, this is the cartilage. It's not shown here. This is the quadrangular cartilage that we usually, when we do septoplasty, we correct it in a procedure called septoplasty. Then you can see clearly the sphenoid sinus and the frontal sinus anteriorly, and the crista galli is shown as well. So the lining of the sinus and the nasal cavity is made up of respiratory epithelium. Anteriorly over the vestibule, we have squamous epithelium, then a transition zone, but that is a small portion. And superiorly over the olfactory cleft, we have the specialized mucosa or lining for the olfaction, which is the olfactory epithelium. But most of the sinus, most of the nasal cavity is covered with respiratory epithelium, which is ciliated epithelium covered with a mucus layer moving with mucociliary clearance. They have lots of respiratory ciliated epithelium as well as goblet cells, and beneath it we have the submucosa with the venous sinuses, and then we have the periosteum, and then the bone separating the paranasal sinuses from the adjacent structures. So it's very important to know that we have three different types of the epithelium, most of which is the respiratory epithelium. A very important thing that I meant to bring it here in a slide, it's very important not only for the sinus nasal cavity, it's also important for the orbit, is the cavernous sinus. We all know that any infection or any tumor, when it reaches to the cavernous sinus, that carry a more morbidity and carry a higher mortality as well. So it's very important to know that the cavernous sinus is communicated with the venous sinuses and the venous drainage of the nose, even the external nose and the face is connected. So an infection there can reach the venous sinus, causing cavernous sinus thrombosis. The carotid artery is passing inside the cavernous sinus. We know that the third, fourth cranial nerve is along the lateral aspect. Then we have the V1, V2, and we know that the abducent nerve is more medial. And this is why we know that nasopharyngeal carcinoma, which is arising in the nasopharynx, not far away from the cavernous sinus, the first presentation or the most common cranial neuropathy is actually abducent nerve palsy, because if it invades the cavernous, it can affect the abducent or the sixth nerve more or earlier than the other nerve. Talking about the blood supply is very important. We know that the nose paranasal sinuses is supplied by the two systems, and we mean by that the external and the internal carotid artery. The external is basically through the maxillary and the facial artery, and the internal is basically through the ophthalmic, which is giving into two important branches, the anterior and the posterior ethmoid artery. They anastomose, especially when we speak about the nasal septum or an area called little area, which is a very small area on the anterior part of the nasal septum. That area is a very common site for nasal bleeding, because it is an area of anastomosis and an area exposed for the external environment and exposed to the dryness. The vein usually correspond to the artery. So it's very important to know that that the artery is coming from two different systems. So this is the anterior ethmoid artery. Here I'm showing the medial as well as the lateral nasal wall. So in this picture, you can see the lateral nasal wall, and you see anterior ethmoid. And we will talk about this in detail more, and we'll show certain CT scan that show the artery much more clear. And here is the posterior ethmoid. But keep in mind that most of the blood supply to the nose is actually coming from the maxillary artery. And the maxillary artery is actually through the third segment branch, which is the sphenopalatine artery. We know that 85% of the blood supply to the nose comes from the sphenopalatine foramen through the sphenopalatine artery. And this is then giving two important branches that goes to the medial nasal wall as well as to the lateral to supply the middle turbinate and the inferior turbinate. And then even it gives branches that goes down below the palate, and then some of these, like the greater palatine, goes back to the nose to anastomose in the area that I spoke about, the little area, or the Kesselbach plexus. So this is for the lateral nasal wall. For the septum or the medial nasal wall, they are somehow similar. We have the anterior as well as posterior ethmoid, but we have the greater palatine, which is one of the branches of the descending palatine, a branch of the sphenopalatine artery, a branch of the IMAX or the internal maxillary, which is a branch of the external carotid. They are all anastomosis, making anastomosis in the anterior inferior portion of the nasal septum. Also, the facial nerve, the facial artery is giving branch through the superior labial artery. They are all anastomosed in this area. So here you can see that this is the anterior and posterior. They are branching out of the ophthalmic artery, which is one of the branches of the internal carotid artery. They are coming from intraorbital, and they go from the orbit into the nasal cavity, and also they give meningeal branches as well. They are very important for us because they are a potential site of injury, and one of the problem of these arteries, especially the anterior artery, anterior ethmoid, is that if we make any transection while it is in its intranasal course, this might retract intraorbitally and causing hematoma. So we always look into it in the CT scan, and sometime if we think that this is at risk, we take precaution by, for example, taking the image guidance or the navigation while the surgery to avoid injuring the anterior ethmoidal artery. So this is one important artery because of its contribution to the nasal blood supply as well as the potential morbidity if injury is happening. Okay. So the artery is always, as mentioned, is coursing from the orbit to the nasal cavity. Here you can see two different CT scan. One of them, the artery, is at the level of the skull base. So this one is not at risk of being injured because it is protected by the bone. But this one, the one on the right side, you can see that the artery is lying below the skull base within a mesentery on both sides. So this one can be easily injured while cleaning the anterior ethmoid air cells or approaching the frontal sinus. So this one, in this case, we take precautions by carefully dissecting the area, and sometimes we use the image guidance to locate it carefully. If this one get completely transected, then this one can retract intraorbital, causing the hematoma. We know that by the anatomy that the artery is about 24 millimeter from the lacrimal fossa. If we are doing any approach from the lacrimal fossa, for example, to control or for ligation in patients with refractory epistaxis or patients with bleeding from the artery, it gets located around 24 millimeter. And from the artery, the anterior ethmoid to the posterior ethmoid, the distance is about 12 millimeter. And then from the posterior ethmoid to the optic nerve, it's about 6 millimeters. So we always memorize it like that. It's about 24, 12, 6. This is the distance, artery, anterior, posterior, and then the optic nerve. So be careful when you see that the CT scan is like this. Definitely we have a classification where we use in order to assess the risk of the injury of the anterior ethmoidal artery. So this is the artery again. You can see that the artery is giving meningeal branches. The artery is, especially the anterior ethmoidal artery, as it courses from the orbit to the nasal cavity, it courses from posterior to anterior. So it is not in a direct coronal plane. So it courses from lateral to medial and from posterior to anterior. So this is a very important thing, because when we are dissecting or doing the endoscopic sinus surgery, when we see something like that, we assume that this is the anterior ethmoid until proven otherwise by locating it or by the image guidance or by the endoscopic anatomy. So this is the anterior ethmoid. The posterior ethmoidal artery is important, but it's not as important as the anterior. Usually this one is protected within a bone, and this one is rarely injured because this one is located within the planum sphenoidal, which is a planum plate that is not easily injured, unless we are talking about endoscopic skull-based surgery, which is a different thing. But during the routine sinus surgery, this is not frequently injured. So you can see that this is the same CT scan, but this is an endoscopic view. You can see that this is the right ethmoid sinus. Now we are already done the ethmoidectomy, and we are looking to the skull base superiorly. And you can see that this should be the lamina papyracea on the right side, and this should be the medial side, and this should be toward the frontal sinus. We see structure which is coursing from lateral to medial and from posterior to anterior. So this one is the anterior ethmoidal artery, which is not below the skull base. It's just within a bone or just immediately below the bone, which is not at risk. So just leave it alone and to avoid injury. The approaches, just in case we ended up injuring the artery, we have different approaches ranging from open to endoscopic. We do endoscopic in case of doing endoscopic sinus surgery. We go transethmoid, but other approaches, as you can see, is also described to ligate the anterior ethmoidal artery. Here I will show you one patient where during the removal of the bony lamellae, we can just. Okay, so here this patient has chronic sinusitis, and while dissecting into the frontal, okay, yeah. So it's playing now. So you can see that this is the artery now starting to bleed from, this is the right anterior ethmoidal artery. This is the frontal sinus, and this should be the lamina papyracea on the right side. Can you see? Is it playing? You can see it running, or? Okay, I think it stopped. Okay. Okay. So here, this is the artery after. So if we see something like that, if it is partially transected, it's not just palpate the eye to make sure that there is no buildup of pressure, and definitely consulting ophthalmology is very important. But if it is partially transected, usually it doesn't retract. So the most important is just to pack the area, wait for the spasm of the artery, and then after the spasm, we can bipolar the anterior ethmoidal artery. This is the most important thing to be done. Leaving it without cautery, he might rebleed again if left untreated. So this is now called the trans-ethmoid approach for the cauterization of the anterior ethmoidal artery. So you'll see now that we will remove the Surgicel, and then the bipolar will be used to cauterize the area. So here you can see the skull base. This is the one. This is the frontal sinus anterior, and then this one is cauterized now. No more bleeding. And then after that, the Surgicel pack was put on top of the artery as a hemostasis, for hemostasis, and that's it. The next part of the tonight talk is the fungal sinusitis. So this part is very important because this infection, as I mentioned earlier, is very strange in its presentation. So if you don't have a good understanding of the different classification, you will not be able to manage it in a proper way. So we divide the fungal sinusitis into two different forms. So the invasive form is the one that has invasion of the mucosa, while if there is no evidence of invasion to the mucosa, the non-invasive, this is now called non-invasive fungal sinusitis. So for the non-invasive, and this is the most common, we have the allergic fungal sinusitis, which is considered the most common fungal sinusitis. We have also the fungal ball, or what we call the mycetoma. This one is also non-invasive part of the fungal sinusitis. But when it comes to the invasive, this one is the one that carry higher morbidity, and this one is not that common. It's very unusual to present. But it's very important because it carry a very high mortality rate, like what you will see in the coming slides. So we divide them into acute and chronic. And we have a special type of chronic, which is called the chronic granulomatous form. So this one is different in its histological appearance, but somehow similar to the chronic invasive, as we'll come to see. So keep that in mind, that we divide the fungal sinusitis into two different based on invasion of the mucosa. The fungal sinusitis is not a single disease, so it's very diverse. They are all sharing that they have the fungus as a playing organism in the etiology. The mechanism of disease is different, so they are associated with a unique radiological feature, and their treatment plan is different, like what you will see in the slides. The prognosis is different as well. And they are usually, the mechanism is through the inhalation of the fungal spore. So they are inhaled into the sinuses, nasal cavity, and from there, the disease process will start. The fungal can be caused by any fungus, but most common is the Aspergillus. The invasive usually is presenting with an acute onset, and usually the patient is presenting in a critical ill condition, and they are having fever, cough, and they have evidence of nasal ulceration as well. The invasive is seen more common in the immune compromised, while the chronic is seen taking a more prolonged course in its presentation. This has been attempted to classify it long time ago based on the invasion of the mucosa as mentioned, and that has been accepted widely as a way of dividing them into two different forms based on the invasion, because we know that the invasive form is usually carrying higher mortality. The initial imaging study is the CT scan non-contrasted. This one will give us an insight into how the sinuses, and if there are any signs like opacified sinuses. The CT scan is definitely better than MRI in showing the bony framework of the sinuses. But if we are thinking of extension beyond the paranasal sinuses into the orbit or intracranially, better to request MRI. That will be delineating the extension of the fungal sinusitis. On the CT scan, we'll see the inflammatory secretion as well as the low attenuation, which is related to the heavy metals. That will it will be shown as the heavy metal is actually is shown as a heterogeneous and hyperdense on CT scan, while the mucosa will be shown as a mucosa thickening as well. So keep in mind that the hyperdensity or the heterogeneity or the double density, we sometimes call it, this is all seen on CT scan, suggestive of fungal sinusitis. But we'll talk about every sinusitis in a separate way and its own radiological features. If we are, this is now talk in general about the fungal sinusitis, but better to differentiate between them all. So on the imaging, the MRI imaging, the appearance is dependent on the protein content. So if this is a recent mucoid accumulation, then this is a more hydrated form. So this will appear low on T1 and high on T2. But as it stays longer period, then this one will get dehydrated. So the hydration status will be less. And then the T1, T2 signal will be reflected or being different than when it is well hydrated. So this is why we look to the T1 and T2. Be careful for the fungal sinusitis, especially because sometimes the radiologist, they might report that the sinus cavity is well aerated, because the fungal sinusitis is showing as low intensity on MRI. So make sure that you look into the both signal and look if you suggest, if you are thinking of sinusitis, better to do the CT scan, because this is the best study for the, especially for the allergic fungal sinusitis. So the most common, as I mentioned, is the allergic fungal. So this one is affecting almost 10% of patients assumed to have hypertrophic sinus disease. This has been known since almost 40 years, and this has been initially discovered after recognizing a condition known as the allergic bronchopulmonary aspergillosis. It's very important to know that the allergic fungal sinusitis is not a real infection. So this one is different from the other sinusitis, because this one is just a hypersensitivity against the fungal organism, which is, or the fungal hyphae or spores, which is present everywhere in the environment. So once inhaled into the sinuses, then the immune system will trigger a hypersensitivity reaction. So this is why we see it in young patients, atopic, and they are immune competent patients. And this one, because of the extravasation of the eosinophil secondary to the allergic response, then we will start see the eosinophilic mucin, which is a mucus rich in eosinophil or dead eosinophils, and the degradation products of the eosinophil, which is more toxic to the mucosa and triggering more inflammatory reaction and polyp formation. So it's very important to understand allergic fungal in that way, that this is not a real infection, rather this is an allergy against the fungal present within the sinus. And this is why when we diagnose these patients, we have a criteria called Bent and Kuhn criteria. A patient has to show evidence of atopy, and they have to have nasal polyposis. And then when we look to the CT scan, we see the characteristic CT imaging finding, which is the heterogeneity or the double density. And then when we operate on them, we see the eosinophilic mucin, which is different than the regular mucus that we see. And then if we send the eosinophilic mucus for the histology, we will see a positive fungal stain. So once we have all these present, then we call this allergic fungal sinusitis. Definitely, if you do fungal specific IgE, you will find that this is raised and sometimes reaching 5,000, and usually secondary to Aspergillus. But the dematicious type can be also responsible for the allergic fungal sinusitis. The most important hallmark for the allergic fungal is the presence of the eosinophilic mucin, which was known before as allergic mucin, because this one is a mucus which is rich in eosinophil or dead eosinophil, inducing or triggering the immune response. So the fungal hyphae also is seen on the histology, and this is the characteristic CT scan finding, where you will see double density, what we call double density, because you see in the center of the maxillary sinus, this is a hyperdense, while surrounding that is a more or a less hypodense. This is affecting both maxillary sinus. Here you can see it also more clear here on the right maxillary sinus, but the left is partially opacified. And in this video, I will show you how the eosinophilic mucin is looking. What do we mean by the eosinophilic mucin, which is one of the important criteria of diagnosing allergic fungal sinusitis. So this is operating now on the left nasal cavity. And here you can see that this is here the left lamina papyracea on this side. And here is the skull base and the septum to this side. Here I'm opening the sphenoid sinus. And then you will see that there is something coming out. This is the what we call eosinophilic mucin, which is basically a mucus with thousands and millions of dead eosinophil because of the initiated immune response against the fungal hyphae or the fungal spores. So when we do the surgery, the most important thing is to clean all that, to keep the sinus cavity clean and well aerated, where later on we will use the irrigation to make it easy for the cleaning and for the topical nasal steroid to reach and suppress the hypersensitivity reaction. So this is why the surgery is important for allergic fungal, and then to be followed by topical treatment in terms of nasal cleaning and nasal steroids. Okay, so this is now the eosinophilic mucin. So the appearance on the MRI is dependent on the depends on the protein content, but we know that the heterogeneity is one important criteria to diagnose the allergic fungal sinusitis. When we deal with allergic fungal sinusitis, this is not a mass, rather because of the acute presentation of this and because of the remodeling of the bone. Usually the sinus affected is showing some degree of wall remodeling, and it will expand with time. And this is why some patients present with proptosis because of the expansion of the ethmoid pressing on the lamina papyracea, and sometimes expansion affecting the skull base. But the good thing about allergic fungal sinusitis is that it respects the mucosa. It doesn't cause invasion, as we agreed. So this is not invading the mucosa at all. But this one, with the remodeling, it will expand with time. So this is a very important thing to understand. It expands, but still the mucosa is intact, the bone is intact, but remodeled and expanded with time. This is different than the other type of sinusitis. So the treatment, as mentioned earlier, is to remove the polyps, to clean the sinus, to remove all the eosinophilic mucin, and from there, post-op, it's very important to continue that with topical treatment. Sometimes we add immunotherapy or oral steroid or antihistamine. So it's very important. So this patient presented this is after cleaning the sphenoid sinus. Patient presented to the emergency with allergic fungal sinusitis affecting the sphenoid sinus and causing compression over the optic nerve. You can see clearly, this is the nasopharynx, and this is the sphenoid sinus. This is the middle turbinate there. And you can see the optic nerve very clear, and pulsation coming from the brain pulsation. This is because of the expansion made up by the fungal growing inside the sphenoid sinus. But again, it respects the mucosa like what you see there. So it doesn't invade the mucosa at all, as I mentioned earlier. So the options in the treatment in allergic fungal sinusitis is oral steroid followed and also the topical steroids. immunotherapy is an option, but others has been mentioned in literature, the antifungal and the topical, the oral and the topical, but they are better to be on selected patients. Is not recommended to use them on every patient, rather a case-by-case decision. The next, so now we are done with the allergic fungal sinusitis. So the next type of fungal, which is considered non-invasive, is the fungal ball or the mycetoma or aspergilloma. This is probably the easiest one of them, because this one is just the presence of a fungal material inside the sinus cavity, is not related to any allergy, and it doesn't induce any allergic reaction. And the treatment for that is very easy. Just removal of that, making wide sinus opening is enough to clear it up. Most of the time, this is caused by Aspergillus fumigatus, but other fungal organism has been also implicated. This affects the immune competent again, similar to the allergic fungal. It has nothing to do with atopy or allergy. So it's very important to differentiate between the two, that the atopy is linked to the allergic fungal sinusitis. Here, we don't need to follow this patient's treatment with any kind of topical steroid. So all what we need to do is just to remove it. And then after removal, nothing needed except follow-up, just to make sure that there's no recurrence. Okay, I think there is a question. Okay, so are there any relation between fungal sinusitis and long-standing use of nasal spray? No. If you mean that the steroid will suppress the immunity and from there the same like what we know in oral steroids, no, this is not the case. In fact, in allergic fungal sinusitis, we keep the patients on long-term steroid spray, because this is the thing which will suppress the immune response and is considered one of the important treatments in order to minimize the recurrence rate. For the other type of sinuses as well, it's not related at all. So it doesn't cause any. It's not related to that at all. So this is how it appears on the CT scan. Most of the time, this is affecting the sphenoid sinus. The maxillary sinus, the second most common is the sphenoid. So the maxillary sphenoid, they are the most commonly affected with fungal ball. Usually one sinus is affected. This is different than the allergic, which usually affect multiple sinuses or one side completely. So the MRI is somehow similar, presence of the calcification, presence of the thickening of the mucosa. They are all similar, but different in the presentation, the clinical presentation, as well as in the sinuses involved. The prognosis, this is the best prognosis among all the fungal sinusitis. Now we come to the first type, or the first form, which is part of the invasive fungal sinusitis. And this one is very important because this type, or the acute invasive fungal sinusitis, is the most fatal. It has been reported up to 80% mortality rate of acute invasive fungal sinusitis. So this one, once inhaled into the sinuses and the nasal cavity, it causes invasion of the mucosa, and then from there the progress of the disease will be seen. It's very important if you receive any consultation typically from an ICU or from the hematology oncology department, or from the emergency with an acute presentation in a patient with an immune compromising condition. So if you receive a consult of such a patient even with minimal complaints like nasal pain, discharge, take it serious and think of acute invasive fungal sinusitis. We know that Aspergillus is a common organism, but also the Mucoracea, which is another fungal organism, is also playing a role. We know that the poorly controlled diabetic more likely to be affected by Mucoracea group, while Aspergillus typically affect the neutropenic patients. Disease is very rapid when it's rapidly progressive. It can be fatal. Very important to have a very high index of suspicion. And on imaging, don't expect to see lots of finding. I mean, all what you will see may be an opacified sinus, mucosa thickening. The most important thing to do is to proceed with endoscopic evaluation, because that will show a pale mucosa, necrosis, sometime nasal discharge, but this is the only hint. And taking a biopsy, you might see taking biopsy, you will see the fungal stain positive for the offending organism. Okay. I think there is another question. So would you start the patient on oral antifungal if the CT scan suggestive of fungal sinusitis? If you are talking about the non-invasive, the one we spoke about, the allergic and the fungal ball, we don't typically use oral antifungal and we don't use the topical, okay? But for the invasive, this is a different story. The invasive, we treat it very aggressively, and we include the antifungal like what you will see in the coming slides. For allergic fungal sinusitis, do you usually try medical therapy before surgical intervention? The classic treatment is the surgery because we are afraid of the recurrence, okay? You can try treatment and many patients might respond, but the problem is the recurrence rate, okay? So this is why we make a very wide sinus cavity and then followed by the topical treatment. It will be easy for the topical treatment once the sinus opening is widely cleaned and the effect of the medication will be easy rather than an opened sinuses. So this is the concept. Clean all the muds, clean all the fungal material, reduce the antigenic load inside the sinus, and then this wide cavity will make the irrigation is easy to reach deep in the sinus to clean the rest and to prevent recurrence. And the topical treatment will reach easily to control the hypersensitivity. This is for the allergic fungal sinusitis. So here in the invasive, the acute invasive, the most important thing is to send patients for endoscopy and to take a biopsy and to start aggressive treatment or medical management, because this is very lethal. Patients, we know that they progress within hours and days. This is the critical point about the acute invasive fungal sinusitis. So the definitive diagnosis is made after confirming the presence of the fungi invading the mucosa with angio invasion, because this one invade the vessels, cause thrombosis, and from there the infarcted tissue will progress. Debridement is very important, but we'll talk about this later. So on imaging, you will see the scan showing mucosa thickening. You might see opacified sinuses, but don't rely on CT scan or MRI, because these are tools to help you. The most important is taking a biopsy and is doing the endoscopy. And if you are still thinking of invasive sinusitis, because this is a very fatal disease, better to start patients on aggressive or on IV antifungal reversal of the immune status. If he is diabetic, ketoacidosis is very important to reverse the immune status that he is presenting with. Here you can see that this is one of the patients with acute invasive sinusitis. You can see that the right maxillary sinus is showing an opacified sinus. And on the slide on the right side, you can see the same opacified sinus, but here we see extension to the cheek and extension to the pterygomaxillary, to the infratemporal fossa, because you see that there is a fat effacement. So these are signs that the disease is progressing, and this is one of the signs that we see on the CT scan for the invasive or the acute invasive fungal sinusitis. So typically the disease progress through the microvascular channel. So it will progress beyond the bony boundary of the paranasal sinuses to involve the orbit, the other spaces, even intracranially. On MRI, you can see also signs to suggest the fungal sinusitis by the presence of the fungal concretion, and better to do MRI if you are thinking of any extension beyond the paranasal sinuses. The MRI is really helpful because it will show the edema, it will show the signs of progression of the disease. One of the unique feature also that we can see on MRI is what we call the black turbinate sign, because we know that the mucosa will enhance on the MRI. So if you can see that there are areas within the sinonasal cavity that is not enhancing, this is a sign that this might be an acute invasive fungal sinusitis. You can see it clearly here on the right side. This is the inferior turbinate on the right side compared to the left inferior turbinate. You see that this is not enhancing because this already involved with the acute invasive fungal sinusitis. The same thing for the middle turbinate, and this is invading intraorbital, and also the masseter, the space is also involved as well. On the right side, on the left side, you see the secretion retained within the right maxillary sinus, but also this hypointense, which is corresponding with the fungal material or the fungal heavy metals or the fungal concretion. So the most important thing here is, as agreed, is the early diagnosis and early initiation of treatment before involvement or extension of the disease and the involvement of the orbit intracranial or the adjacent intracranial vessels. So you can see clearly here that this patient has been operated. This is a sign of operation, yet despite the surgical intervention, the disease was progressing on the left side. Compare the right cavernous sinus, which is enhancing, with the left cavernous sinus, which is already thrombosed. So this is a sign that this disease has already reached intracranial, and this unfortunately is a poor sign, carrying a higher risk of mortality, as mentioned earlier. For the acute invasive fungal sinusitis, the mortality, as agreed, is very high, but recently, because of the recent awareness and the IV antifungal we are using, there is a downward trend of improvement of this high mortality, and still it's high, reaching up to 18%. But this is still, if you are dealing with mucor, the mucormycosis or the mucor organism is carrying still a poor prognosis. So still deal with it, and the basic concept is to initiate an IV antifungal, to do aggressive debridement, surgical debridement, and then to also reverse the immune status of the patients as much as we can, especially the diabetic ketoacidosis. Now we will move to the second type of invasive, which is the chronic. This one, it takes a more prolonged course. I will try to finish within the next 10 minutes, hopefully. So the chronic invasive is different in that this is taking a more chronic course. Okay, I will just answer one question before proceeding to the chronic invasive. So for allergic fungal, do you usually try medical therapy before? Okay, I think I answered that question. Just okay. Hyperbaric therapy has any role in mucor sinusitis? Well, that has been described, but there is no evidence that this will change the mortality rate. Keep in mind that these patients is usually immune compromised, and they are usually patients presenting or within the ICU. So it's not let's say practical, but in any patients, if you have hyperbaric, definitely I will try it, given the high mortality of the acute invasive fungal sinusitis. But what we know making difference is the early initiation of treatment and the aggressive medical management and the surgical management as well. So the chronic invasive fungal, as I mentioned, is more chronic in nature. It's not carrying a higher mortality, the same like the acute invasive. Usually patients are immune compromised. And patients usually are on immune suppressive treatment. Typically, patients present with picture of chronic sinusitis, but later on, when biopsy is taken, this will confirm the presence of fungal invading the mucosa. Patient will present with nasal polyposis, and they will some of them on histology is showing evidence of mucosa invasion as well. So the most important thing here is to again initiate the IV antifungal, and also to initiate the surgical resection is definitely playing a role as well. Keep in mind that this, if not treated, it can progress and invade adjacent critical structure. You can see clearly here that this is the right sphenoid sinus with remodeling and invasion of the right carotid. The left sphenoid sinus is clear of the disease. The prognosis here for the chronic invasive fungal sinusitis is dependent on the systemic antifungal agent. The overall mortality is lower than the acute one, but we know that once the intracranial component is involved or the cavernous sinus is involved, the higher the mortality rate is high. And we tend to do conservative endoscopic resection rather than aggressive compared to the acute invasive fungal sinusitis. This is now the last type of fungal sinusitis, and this is called granulomatous. So it is one of the invasive fungal sinusitis, but this one is different than the previous one in that this is making or forming granuloma. So the management is somehow similar. We know that the organism is different. So the most common organism here is the Aspergillus flavus. And typically these are immune competent patients, and the geographic distribution is also different. This is very common in Africa, Southeast Asia. So it has a very unique geographic distribution, slowly progressive, with Aspergillus flavus as the most common. So this is somehow different in its presentation compared to the chronic invasive fungal sinusitis. We did a case series looking for the chronic granulomatous invasive fungal sinusitis that we have seen, and we have 7 cases reported in our paper, and they are again similar to what has been reported in the literature in that they are immune competent. They present with chronic sinusitis picture, but some of them they might present with proptosis or medial canthal swelling. These are invading the mucosa, and it might extend to the orbit or intracranial. And Aspergillus flavus is the most common, as I mentioned. The most important thing is to initiate oral voriconazole. This has been shown to have a good response for the chronic invasive sinusitis. And the prognosis is dependent on factors. The most important one of them is the intracranial extension. So here is the hallmark for this invasive fungal sinusitis is the presence of the granuloma. This is a non-caseating granulomatous formation. The imaging is somehow similar to the other invasive fungal sinusitis, but this is usually presenting with a mass, and taking a biopsy will show the organism causing the invasive fungal sinusitis. The surgical resection or the debulking, followed by the aggressive medical treatment, especially the voriconazole, has shown good results in many patients. So this is patients with the granulomatous sinusitis showing pre and post voriconazole oral treatment with an excellent response. So this is just a review of the invasive, because these are the one considered carrying a higher mortality. So you can see that the acute is mostly related to Aspergillus and the mucor. The chronic is Aspergillus fumigatus, but the granulomatous is mostly affected by Aspergillus flavus. They are immune compromised, with the exception of the granulomatous. They are immune competent. The acute is presenting acutely. The chronic, they usually take a more longer course, and they have geographic distribution only in the granulomatous invasive fungal sinusitis. So this is very important when we deal with invasive fungal sinusitis. Okay, so one question that for how long do we keep patients on voriconazole? Well, definitely we need to keep the ID involved with us. There is no, agreement on how long typically we keep them, but at least until we have a recurrence, typically for 6 months, okay? But again, the goal is to have complete resolution, follow-up images until we have a complete resolution of the fungal mass causing the chronic invasive fungal sinusitis. So this is the most important thing. So now we are done with the fungal sinusitis. I will just take you into an important topic that, not a topic, rather it's a video talking about orbital decompression. I know that the time is time is approaching, but this is just to show, because this is very important, and I'm sure that you see patients with Graves' orbitopathy, and then we'll finish with the DCR in 3 or 4 slides. So this is now doing, patients is actually presenting with Graves' orbitopathy, and we are doing now the medial orbital decompression. We are done the ansynctomy, now we are doing the ethmoidectomy, and then we are, you can see clearly here the lamina papyracea on the right side. This is the wide right maxillary sinus. And then once we are exposing the lamina papyracea from the intranasal part, we remove the mucosa. And then after removing the mucosa, we start dissecting the lamina papyracea like what you will see in the coming. Yeah, so this is now removing the bone. And then you will start seeing the periorbita. After seeing the periorbita, we'll make incision in the periorbita to expose the orbital fat, and then from there the decompression into the medial side to show to resolve or to reduce the intraorbital pressure. So now we are making incision, incising the periorbita. So this is the right eye, the medial orbital wall. You start seeing the orbital fat, making another incision also. And this is the right maxillary sinus, or the orbital floor. Once we are done with that, we'll just connect or make incision between the two lines just to finish the medial orbital decompression. Okay. So this is, I'm sure that this is a very important thing for you, the dacryocyst rhinostomy. So the dacryocyst, I will just talk quickly about the anatomy. I'm not going to show videos here, but just to show the anatomy from the endoscopic endonasal aspect. So why you make incision in orbital fat? Incision in the periorbita, so we allow the decompression. Otherwise, the periorbita will retain the intraorbital pressure. So this is the reason for the incision of the periorbita. So the picture here, you can see clearly that this is the nasolacrimal duct with the sac. Typically, the sac is about 3 to 8 millimeter above the insertion of the middle turbinate, right side here. And keep in mind that endoscopically, the sac is above the insertion of the middle turbinate. This is very important when doing endoscopic DCR. So when we make incision, we make the upper incision. So basically, we do posteriorly based flap. So this is the left nasal cavity where you can see clearly the left middle turbinate. This is the left middle turbinate with its insertion. So the incision is made above the insertion, extending about 10 millimeter and then down, making it a posteriorly based flap. Once that is done, you will see this line, or what we call the anterior maxillary line. So this one is the suture between the frontal process of maxilla and the lacrimal bone. Then we elevate this flap and then dissect or remove the bone with the Kerson rongeur. After that, you will see the sac, and this is an agar nasi cell. The flap is reflected posteriorly. And then after that, we make the incision into the sac, vertically oriented, a little bit posterior, so reflecting the anterior leaflet over the anteriorly, and then the posterior will be in contact with the posteriorly based flap. Once that is done, then the nasal, the silicone tube is fixed with the clip, and I will end up with this slide. Thank you very much, and if you have a question, please feel free to ask.
Thank you very much, Dr. Ahmed. Excellent presentation. I have a question for you. During external DCR, sometimes we encounter anteriorly placed ethmoid air cells. You have any tips on how to deal with it? I tend to clear the bone and remove the mucosa, but sometimes they bleed. So if you can give us any tips on how to handle them.
The anterior ethmoid, which is related to the DCR, is basically the agar nasi. So I would say the best is actually to go endoscopically from the inside, because this will this is what we are familiar with. This endoscopic anatomy is really easy, because that is the location corresponding to the nasal lacrimal duct. But I would say if you have an endoscope, if you have an ENT, definitely this will help. The cell there located, as I mentioned, is the agar nasi. Just try to, if you could see the insertion of the middle turbinate, this might reorient you back toward the anatomy. But that's how it goes. I prefer the endoscopic because the anatomy is much more familiar and easier to run.
Thank you. I can see that we have some questions from the audience. From Dr. Hamid, he's asking about how long, or should you continue using voriconazole, or would you debulk? We had some discussion about that. How long will you give it for? 6, 8 months, 12 months, or 2 months, and then you would debulk the fungal elements from the orbit?
Yeah. For the chronic invasive granulomatous, or even the chronic, you need to debulk because you need to have a biopsy in order to diagnose. This is very important, and this is the case in most of the time. They present to us similar to other chronic sinusitis. We go in, we see that this is different because they present as a mass-like, not typical nasal polyposis. We take a biopsy, we debulk, okay, and then we confirm the diagnosis of chronic invasive fungal or chronic granulomatous. More chronic granulomatous because those usually are immune competent. So we have no clue that this might be chronic. Then after that, we initiate the voriconazole. Typically, I would say I leave the decision for the voriconazole for the ID. I prefer not less than 2 months, yes, and dependent on the patient's response. For the second question, Dr. Hamid. Okay, يعطيك العافية Hamid. Okay, Dr. Amr. Okay, Dubizent. If you can just write the generic name for that, is it? Typically for the antifungal, we use the oral, the voriconazole. We use the liposomal amphotericin B, so that one. But because of the nephrotoxicity and the higher morbidity associated with it, we like to use the voriconazole. So this is the reason for, but this is for the invasive fungal sinusitis, okay? For the non-invasive, we don't use the oral or the topical antifungal. Okay, so how do we differentiate bacterial or sinusitis in general? You mean bacterial or fungal? Well, the bacterial is usually, if we are talking about acute bacterial sinusitis, they usually present with headache. They usually present with purulent nasal discharge, with the presentation that is usually more than for the acute is less than 4 weeks. But when we take an endoscopy inside, we will see the presence of pus coming out from the middle meatus. So this is one way, and if we took a swab, then we will confirm the presence of bacteria. So this is how we usually treat it, how we usually diagnose it and treat it. For the fungal sinusitis is totally different. As I told you, if you thought that this is complicated, then better to do CT scan, because CT scan will help you a lot because of the special finding that you will see, like the heterogeneity seen on CT scan. Okay, lab-wise, we don't rely on laboratory for the diagnosis for the fungal, but this can help us, like in invasive fungal sinusitis, because for example, the absolute neutrophil count or the neutropenia will guide us in management of acute invasive or chronic invasive. Okay, Dr. Hamad, what instrument do you use to debulk the middle turbinate, which we sometimes need to place Jones tube? Okay, well, the middle turbinate, we leave it in place. What we remove is basically the lacrimal bone and the part of the frontal process of the maxilla, and we use the kerosene for that. If needed, we use sometimes the drill, okay, but kerosene is usually enough to remove the bone and expose the sac and then creating the incision. Okay, monoclonal antibody. Well, I have no experience in that for the treatment of fungal. We know that the most important thing is we ask our colleagues to infuse them with neutrophils, with the granulocyte colony stimulating factor. It does help for some time. The reversal of the immune status is very critical, and the early initiation of antifungal and surgical debridement. This is the well agreed on in the management of acute invasive fungal sinusitis.
We see very aggressive, not aggressive, or rather aggressive cases that go into the orbit that's been there for years and from the south of the country. Maybe we should collect our cases and report them with you.
Yeah, sure. And I have seen patients maybe a year ago presenting, maybe the one I show in in one of the slides, presented with a medial canthal swelling, and they planned for him for surgery for debulking because he was already diagnosed actually with fungal, because that medial canthal swelling, an FNA was taken in another hospital confirming the presence of or the diagnosis of chronic invasive granulomatosis sinusitis. Then once we initiated the voriconazole, it completely resolved within a week. So, and the patient disappeared. I think he followed for 2 or 3 visits, then he disappeared after that. But I think the voriconazole, it does help a lot. But for the acute, the aggressive treatment, I agree, it has to be all initiated, including the surgical debridement.
Thank you.
Allah يعطيك العافية. Okay, I think we have one
There's a question, yes, from Naif Suleiman regarding inframedial decompression. Can you read that?
Yeah, sure. So we see some patients get overcorrected with ophthalmos, with collapsed maxillary sinus on imaging. Is there a way endoscopically to try to re-aerate maxillary sinus to try to decrease the periorbital prolapse? Okay, so maybe you have seen in the video, this is why most of the roof of the maxillary sinus has been kept intact. And not only that, there is a support posteriorly because we are afraid of the prolapse or the ophthalmos. So this is very important. We are in the endoscopic, we can decompress it medially. We don't want to end up having this complication. So this is, but I mean, to treat it if it happened, I haven't done this in any patients, but I think supporting the eye maybe, but I have no experience in this, so I can't answer it with confidence. But I would say the most important thing is prevention. Just decompressing the same like what you saw, removing making incision in the periorbita and then allowing the fat to herniate into the ethmoid air cell. This is the most important thing. I know that it has a limitation. Some patients, they might need a decompression more than that, but this is the limit of the medial decompression.
I do external decompression. I don't do endoscopic, and I leave the strout between the medial and the inferior wall, and it helps keep the globe in the proper position.
Yeah.
Great. Thank you very much. It was an excellent presentation, very enlightening, and we really appreciate spending time with us. Thank you, Dr. Ahmed.
يعطيكم العافية جميعا.
Thank you. Have a good evening.